Good evening all to the 117th session of the weekly Huddle. I'm your host, Anoop Agrawal, and joining me today is my friend and co-host, Praneeth Pulamuri. We both are cardiologists working at KIMS Hospital, Secunderabad. This is our 117th episode where we typically talk about common clinical scenarios, which we otherwise would discuss in a casual hallway discussion, but we try to make it a little bit more formal and discuss in an organized platform like this one. Today's topic is something which is very basic for cardiologists, and I believe to a certain degree, even for general physicians, these are common entities that one may encounter. So I'll directly go to today's case, and after I brief you about the case discussion, as a customary, I'm going to ask my colleague Praneeth for his impression, and then I will take opinion from each one of you. If you do have any questions or comments about the topic or about the discussion, please type it in the chat box, or you can raise your hand and I'll give you a chance to speak. So today's case is a 34-year-old guy. He is a businessman. He is a resident outside of Hyderabad. He's actually visiting Hyderabad for an elective cholecystectomy. He thought that he can get a better service at Hyderabad. He lives about 250 kilometers away from Hyderabad in a tier 2 city. The surgery was originally scheduled last week, but it was postponed because at that time he reported he was having some fever and upper respiratory tract infection, like symptoms like cough and cold and some sore throat. He was prescribed some symptom controlled medications and was told to come back later for elective cholecystectomy. At that time, other than those symptoms, he otherwise was fairly okay. There was no any signs of acute cholecystitis at that time. He did have an episode of acute cholecystitis about 6 months back, which at that time was conservatively managed. And the plan was to do an interval cholecystectomy, and that's how this event came. He otherwise does not have any other comorbidities. Now, for the past 2 days before he visited me in my OPD, he had been complaining of some on and off chest pain, which while he was putting it at the precordium level, it was poorly characterized in terms of exercise or in terms of any kind of exertion. He did describe that there are at times where changing position may increase or decrease the chest pain, but he didn't quite pay too much attention to that. And it's a nagging pain which is sitting on his chest. And of course, with the chest pain, he's concerned about his heart. So he went to the same hospital where he got evaluated for acute cholecystectomy, where a routine evaluation was done. And that routine evaluation showed the following findings, which I'm going to discuss with you. So a diagnosis of acute pericarditis at that time was made, and the patient was advised to see a cardiologist, and that's how the patient came to me. So in the preliminary investigation, he underwent routine labs, including LFTs, which were normal. He had an ECG done, which showed 1 millimeter ST segment elevation involving limb leads 1 and 2, augmented leads of left and inferior, and precordial leads of V2 to V6. Echocardiogram was also done, which showed good LV function and a small circumcardiac pericardial effusion, which was pretty much surrounding 360 degrees. And at the max in diastole, it was measured around 5 millimeters or so without any, with normal filling pattern, no evidence of tamponade. He also did undergo ultrasound abdomen in case if that chest pain was a mimicker for his cholecystitis, and that ultrasound abdomen showed gallstones without any evidence of acute cholecystitis. In his labs, the only thing which were remarkable was ESR, which was elevated to be 62. All other lab parameters were normal. So now he is in my OPD, and I'm trying to identify what treatment strategy I'm going to put him on. So I have labeled few of the discussion points that I need to discuss about this particular case. So Point number one, does this patient fit the diagnostic criteria for acute pericarditis? With the given information, are we pretty sure that we are dealing with acute pericarditis and nothing else? And do we need to do any further investigation to conclusively make that diagnosis? Then how do we decide this patient? I'm seeing it in my OPD. So the decision-making algorithm to talk about whether I can manage this patient as an outpatient or whether I need to admit this patient early on for observation and initial treatment. Talking about treatment, what would be the initial management strategy and how to minimize the risk for recurrent pericarditis and on the same line, constrictive pericarditis in the future. Then there are other additional questions which I put in because I think they are going to be relevant. Like this patient needs cholecystectomy. So when can he go for cholecystectomy? Now, since he has this findings on ECG and echo, do we need to postpone the surgery or can he go for surgery now? And since there is a small pericardial effusion, does this patient need any diagnostic or therapeutic pericardial tap right now? And if not right now, how do we decide when these patients need a pericardial tap? So these are some of the discussion points that I have for this case. I'm not sure if I'll be able to address each of these, but we'll try to do it over the next 45, 50 minutes or so. So Praneeth, if this patient were to come to you, please walk us through what will be your thought process, and then I will ask the rest of my attendees about their impression as well.
Yeah, good evening, everyone. So young male who is complaining of retrosternal chest pain and who has ECG showing some ST elevations. Though echo does not show any regional wall motion abnormality and the LV function is good. First thing that I want to definitely rule out is an acute coronary syndrome. Though the probability of acute coronary syndrome here looks less likely because the severity of pain or no associated symptoms and equally ECG and echo not correlating completely. So, and if ECG is also suggestive of the classic signs of pericarditis, like both ST elevations and PR depressions are there, then probably the diagnosis of pericarditis is made. But before I label it, I always want to be sure not to miss any acute coronary syndrome. I would suggest this patient to undergo troponin. Also knowing that pericarditis may not be isolated. Pericarditis can have an associated myocarditis also, which equally helps me risk stratify these patients as to whether they are in mild risk. If those patients who have an associated myocardial involvement also, there seems to be a more burden of inflammation. Then regarding further treatment and evaluation and prevention of constrictive pericarditis in the future, most of the pericarditis are viral and they are self-limiting. Maybe for 2 weeks or so, they should subside on their own, and they usually do not lead to any permanent damage. And management would be essentially to give some NSAIDs to help relieve the pain, because pericardium is a very sensitive structure, so the amount of pain experienced by patient may be quite significant. So NSAIDs are said to be the drug of choice, which not only reduce the inflammation and help in reducing the pain. Maybe like ibuprofen probably is the drug of choice. Sometimes now colchicine has also been tried to reduce the inflammation and more importantly to prevent recurrences. But I believe for most of the patients, for few days of maybe paracetamol or ibuprofen should do the job. Do we need to do anything else? Probably no. And I believe with giving him some time for maybe a week or so, he should be recovering fine. I think those are the questions. Anoop, anything that I'm missing?
Praneeth, outpatient or inpatient?
Yeah, because the patient is hemodynamically stable, other than pain, rest of the parameters are okay. We can manage him on outpatient. No need for admission, unless he has any hemodynamic instability, which is not there. Most of them, or at least this patient, can be managed on outpatient basis.
And what do you mean by hemodynamic instability for these guys?
Any blood pressure being on a lower side, or if he has any complaints of breathlessness, those are the issue. Other than that, I won't. I'll be having very high threshold for admission. Most of them can be managed on OPD basis.
Would you consider a non-viral etiology for this pericarditis? There is a history of fever, but are we certain this is viral only?
Majority are viral. So if most of them should subside within a week's time. If the pain is, if the fever or the pain is not subsiding, then probably I would consider other etiologies like any bacterial or even inflammation. But majority should be viral, in my opinion.
Any role of doing a diagnostic pericardial tap in this?
Not needed. The risk of doing a procedure versus the benefit of getting any information, if you look into it, the risk is higher here. So I would not recommend, particularly when the pericardial effusion is very minimal. Chances of injuring the heart is high. So if it is only minimal effusion, I would avoid doing a diagnostic pericardiocentesis. I would manage them as a probable viral pericarditis and treat them and see how they respond.
Give me a scenario where you would actually do or advise a tap in these kind of patients.
When if the first thing to do a tap, I would make sure that the effusion is significant enough where I can safely access the pericardial space without injuring the myocardium. So if that situation is there, then I would venture into it. If not, then I will not do shows. Most of the time, the pericardiocentesis are done for relief of tamponade, and maybe for sometimes if you think that there is some tuberculosis or malignancy, then you try to do pericardiocentesis. But for majority of the patients with very minimal effusion, as described in this case, will not deserve pericardiocentesis, in my opinion.
And last question, when will you clear him for surgery?
I would ask him to wait for at least 4 weeks. Usually, any viral fever as a notion probably should will take about week to 10 days time, and because he also has features of inflammation, ESR is elevated, so he definitely has an active inflammation at this point of time. And because it's an elective procedure, I would ask him to wait for 4 weeks, so that 2 weeks of illness and another 2 weeks of recovery where all the inflammation has subsided, and he should be in a better position to take up the elective cholecystectomy.
So 1 month is what you would think?
Yeah.
So one thing that I missed when you said you will like to do troponin on this patient, right?
Yeah.
What if the troponin comes positive?
It indicates that the patient has associated myocarditis also, in addition to pericarditis. And depending on the amount of elevation, you can risk stratify this patient on how severe is the inflammation. If the troponin is significantly elevated, then I would probably be admitting this patient for a day or two just to make sure that he's recovering fine. Versus if the troponin is negative, then I know that there is only pericardial involvement, and I can risk stratify this patient as low risk. So to risk stratify this patient, troponin will help for me.
Thank you, Praneeth. I'll move on with my other attendees for this discussion. And if any one of you have got any questions, comments, or anything, you can please put it on your chat box or raise your hand, and I'll give you a chance to speak. I'll head over to Shankar sir. Shankar sir, it is very much possible that you would be the first guy looking at this patient. So I have already put up the questions, the discussion points that I want for this particular patient. But one particular question I have for you is, would you be managing these patients yourself or would you be sending this to cardiologists? So while you answer all the other points that I have put it for the discussion, also if you could address this, that do you think at like what will be the trigger for you to refer this patient to a cardiologist? Shankar sir.
Good evening to all. This is an interesting scenario. Sometimes we come across in our clinics. Most of the times they hear it is a clear-cut case of acute pericarditis, because the criteria fulfilled in this case, the chest pain, especially it will be sharp in nature and the pleuritic type of pain, increases with the inspiration, and while in supine position it will be aggravated, and if he gets upright it will be little relieved, and if he leans forward also he gets maximum relief. So this is a typical case of typical pain of pericarditis. So a typical pleuritic type of pain. So second is when comes with this type of pain, we have got multiple differential diagnoses other than this pericarditis. Pulmonary embolism, myocardial infarction, the acute aortic dissection, and so many things they should be ruled out. So second is pericardial friction rub. If it is accentuated, see with the diaphragm, it will be very much appreciated, and if you press the diaphragm, it will be more appreciated. So if he leans forward, this will be more accentuated and will appreciate pericardial friction rub. The third one is the ECG changes. So ECG changes if there is a diffuse ST elevation, not confined to the vascular area, but then is associated with the PR depression. That is very much important. So characteristic changes in the ECG, and if I got a echo, then there will be mild effusion, mild, moderate, and severe effusion. So new or worsening effusion. If out of these four criteria, if the two are there, it is a definite diagnosis of acute pericarditis. Then whether he should be treated outpatient or inpatient, should be admitted. So most of the times the etiology of this type of acute pericarditis is usually idiopathic or viral mostly. The viruses like Coxsackie, echoviruses, influenza, and the recent the corona, the Epstein-Barr virus. So many viruses are there. So then if patient has got a persistent fever, then if it is going into the incessant or subacute course, when we suspect a cardiac tamponade, then if there is a history of acute trauma, the patient is on oral anticoagulants with this acute pericarditis, definitely they should be admitted. Sometimes it may turn out to be hemorrhagic pericardial effusion. So at the same time, as Dr. Praneeth has alluded to, so we do biomarkers like troponin. Then if it is troponin is elevated, we should, along with the acute pericarditis, we should suspect the myopericarditis. So myocarditis is also involved. Myocarditis also is a component in this case. So in these situations, a patient has to be admitted. If it is low risk, uncomplicated, then usually he can be evaluated and he can be sent home and with outpatient follow-up. So this is a clear-cut case of acute viral pericarditis. So what I do in my clinical practice, we give NSAIDs, aspirin, ibuprofen, so many are there, but I give personally indomethacin. I put them on indomethacin 25 to 50 milligrams 3 times daily for 1 to 2 weeks. Then along with the indomethacin, I give colchicine also. Colchicine is found to be better anti-inflammatory in this case. So 0.5 milligram tablets are available in India, but whereas abroad 0.6 milligrams are there. So 0.5 milligram tablet colchicine, the Goutnil or Jai colchicine available in the market. It can be given orally twice daily. I give for 3 months. So even though we give NSAIDs like indomethacin, ibuprofen, aspirin and all for 1 to 2 weeks, but the colchicine has to be continued at least for 3 months. We should restrict any strenuous activity. The patient should be given bed rest, because the strenuous activity it ultimately leads to a recurrent pericarditis. If he doesn't respond to these NSAIDs and colchicine, then I put them on glucocorticoids. So initially, I don't start the steroids, prednisolone, but in conditions like chronic renal failure, a pregnant woman more than 20 weeks of gestation, so any systemic inflammatory disease where we suspect this due to bacterial pericarditis or tuberculosis. So tuberculosis we can give, but in the systemic inflammatory conditions like pneumonia and all, so where we don't give glucocorticoids initially, there we give only NSAIDs and colchicine. If it doesn't respond, we start them on glucocorticoids. And then I personally see many schools of thought are there regarding some people, they start with the high dose and rapid taper they do with the glucocorticoids. But personally, in my practice, I give 0.2 to 0.5 milligrams per kg body weight, low or moderate effective dose, 0.2 to 0.5 milligram. But the higher doses are 1 milligram per kg body weight, 1 to 2 milligram per kg body weight. But I don't, I follow only a low effective moderate dosage and gradual tapering. I don't do rapid taper, because rapid taper and high dosage will lead to recurrent pericarditis. That's why we give prednisolone at a lower dose and a gradual tapering over 2 to 3 months, along with the colchicine, because already we have given NSAIDs for 1 to 2 weeks, no response. Then colchicine has to be continued for 3 months. Then we should add glucocorticoids. Suppose while treatment on glucocorticoids and colchicine, if he complains of chest pain again, then we have to give aspirin. I just like what do we give in first line therapy. But this is what I do. Suppose if he doesn't respond, then other drugs are there, like if we suspect any autoimmune disorders like systemic lupus erythematosus or rheumatoid arthritis, those conditions I leave it to either rheumatologist or cardiologist to continue the further the interleukin-1 receptor blockers like anakinra, rilonacept and all. So some disorders like inflammatory autoimmune disorders, azathioprine or IV immunoglobulin, they should be given under the supervision of a rheumatologist or cardiologist, the fourth line of therapy. So if the patient has got a recurrent pericarditis, I send it to institute for the further investigations. And the second is the patient has got suspecting cardiac tamponade, immediately I send it to cardiologist for the pericardiocentesis. These are, and the patient is going into chronic and effusive constrictive pericarditis or constrictive pericarditis, then I definitely send it to institute for further evaluation by cardiologist and for any pericardiectomy by surgeon. So this is my approach. Initially, only 1 to 2 weeks only I keep it with me. If he respond, most of the times they respond because it is most of the times it will be viral or idiopathic. And with the NSAIDs like indomethacin and colchicine, they will respond. If they don't respond, I start them on glucocorticoids. Then while on glucocorticoids and colchicine, if the patient develops complaints such as pain, I add aspirin. For the fourth line of therapy, like the IL-1, this interleukin-1 receptor blockers, rilonacept or anakinra, then immunosuppressive agents like azathioprine, then immunoglobulins. So I personally, I leave it to institute only for the management. This is my, but only in clinical practice, sometimes we get confused with early repolarization syndrome because of the ST changes. Then the acute myocardial infarction. Then, as I told, the pulmonary embolism, aortic dissection. These should be evaluated by further investigations before we label it as acute pericarditis. We should not miss this acute coronary syndrome in this case. So, because in myocardial infarction also, patients they are present with pericardial rub. So here we don't give glucocorticoids or NSAIDs because they interfere with the healing process. There I prefer to give aspirin and colchicine. Aspirin, already patient will be on 75 or 150 milligrams of aspirin. So we will increase the aspirin dosage to 2 to 3 grams of aspirin along with the colchicine. Thank you, one and all.
Sir, one question for you before I let you go. That is, at this juncture, if the patient were to come to you, I have described that he has got some basic labs done. He has got ECG, echo, and ultrasound done. At this point of time, are you happy with the investigation and you are ready for treatment, or you would like to investigate a little bit further, like Praneeth wanted to do a troponin? Is there any other investigation which is required at this point of time?
See, other inflammatory markers we will investigate, because if inflammatory markers are present, the patient has to be admitted, especially because inflammatory markers like the C-reactive protein or WBC count is raised, leukocytosis, or ESR is elevated. These are the reactive markers. So there, definitely I will admit him for further management and for further follow-up also. If we, most of the times in my clinical experience, 1 to 2 weeks, they respond. So the pericardial rubbery disappears and the pain, especially pain subsides, and the ECG changes also will be coming down, and the pericardial effusion, which was detected by echo, will be reduced. So that time we'll taper the dosage of this anti-inflammatory drugs for up to 3 months. Then at least see, if he has to undergo surgery, he has to wait for 3 months, because the anti-inflammatory therapy has to be given for 1 to 2 weeks, and the tapered dosage every week we taper, and up to 3 months. then the colchicine has to be continued for 3 months. So surgery has to be postponed for at least 3 months.
And sir, let's say you started him on these medicines. When are you going to call him back for a review?
Every week. See, if he is a treated outpatient, we have to ask him to come every week. Then if all these the symptoms, signs have subsided, the inflammatory markers also coming down, then we'll start giving a tapering dosage. Suppose the patient is on indomethacin. Most of the times I put them on indomethacin. I don't know the others. So earlier aspirin and ibuprofen was preferred abroad, but in India, myself, I prefer only indomethacin. It is a very good drug. We give in rheumatological practice also. It is a wonderful drug. But only thing is gastrotoxicity has to be kept in mind when we give these NSAIDs. Then when we give colchicine also, there will be some GI disturbances will be the same. 1 to 2 weeks. So after 2 weeks, I start tapering if the response to this therapy. At the rate of at least I reduce by 25 milligrams per week and stop it this indomethacin. But colchicine has to be continued for 3 months at the dosage of 0.5 milligram orally twice daily. Sometimes once daily also, sometimes it will be sufficient enough. If the guy, lady, less than 70 kg, we can give an even 0.5 milligrams once daily also. But in my recurrent pericarditis, this colchicine has to be continued for 6 months.
Thank you so much, sir. I will move on with my discussion. And I remind my attendees, if you have any questions, comments, then you can either type it on the chat box or you can unmute yourself. I will ask my colleague Santosh for his opinion. Santosh, if you can hear me, could you please unmute yourself? And I want you to share your thoughts about this case, but I have a particular question for you. Praneeth wants to manage this patient as an outpatient. Shankar sir also wants to manage this patient as an outpatient if the inflammatory markers are normal. My question to you is, how do I know this is not a bacterial, or somebody put it in the chat box, this is not a tuberculous pericarditis, just based upon the information that I have got, because we know that the bacterial and tubercular pericarditis, they typically have a much more aggressive clinical course than idiopathic or viral pericarditis. So, Santosh, first of all, your thoughts on this case, and secondly, in the OPD, are you pretty confident that you are not dealing with either of the two and you can manage it as an outpatient? Your thoughts.
Good evening, sir. First of all, there are certain criteria for admitting the patient, and one of the criteria is if the patient is running a high-grade fevers, let's say 102, 103 degree Fahrenheit, and patient is having a toxic look. Such patients, most of the time, they're bacterial in nature and needs to be admitted. Number one. Number two, if we find the effusion is more than mild, moderate effusion, which we don't know if it overnight or next day, if it accumulates and make the patient to go into hypotension, such patients also needs to be admitted. And again, the hypotension patients, if the patient has got a raised jugular venous pressure, there are some criteria. And again, if the patient is immunocompromised, these are the patients where we need to admit and do the investigation and treatment. Number one. Number two, sir, regarding what Dr. Shankar sir said and what Dr. Praneeth sir said, I agree with whatever they have said. The one point I want to discuss is that need of coronary angiogram in a patient who comes with acute pericarditis. So most of the time we do a chest troponin, and there is some element of myopericarditis existing. Obviously, we are going to get a raised troponin in such patients. Does that warrant to do angiogram, or specifically look in from the echocardiac point of view, see, find out any RWM in any coronary territory that's a telltale sign of ACS, and selectively such patient needs to undergo coronary angiogram. Why I'm asking is because in a previous institution where I worked, one of the diagnostic test was a coronary angiogram in all the acute pericarditis patients. They have to undergo angiogram. So that was this thing we have followed. And regarding rest of the things, I agree with whatever Dr. Shankar and Dr. Praneeth sir has said. Sir.
Thank you, Santosh. Praneeth, I'll ask this question to you, and then I have one more question for you. But what do you think? Do you think all pericarditis patients with positive troponin need to undergo an angiogram?
Not necessarily. If the clinical picture suggests it as an pericarditis or myopericarditis, then they don't need an angiogram. Versus if the probability of coronary disease seems to be there, like if the patient is maybe 40 years or more, who has any history of hypertension or diabetes, then probably it is worth doing a diagnostic coronary angiogram. Not for everyone.
So one thing you mentioned was 40s and age 40 and hypertension. Like you said, clinical picture suggestive of pericarditis versus give us some more example. Now, what would you think that these are the clinical pictures where you would like to do an angiogram?
Like for some, you are pretty confident that this is definitely pericarditis because the ECG is typical. It has a classic ECG findings of ST elevations and PR depressions, and echo LV function is fine. Troponin is not that elevated. No associated symptoms. Your certainty of dealing with pericarditis is high. Versus sometimes you are not completely sure. The ECG changes may not be may not be classical of that, and patient if is of a bit on an 40 plus, any male 40 years, we know that the coronary artery disease needs to be ruled out. Though it's not always the case, but still at least I put a cutoff of 40 in a male, and any other associated risk factors in the form of hypertension, diabetes, any history of dyslipidemia, any family history, obesity, something like that, where for me, the threshold to rule out coronary artery disease is low. So I want to rule out whenever there is a possibility. Also understanding that we do not want to touch the coronaries when there is an active inflammation also. So most of the times I would not try to do angiogram, but when I'm not completely sure, then probably I would like to do angiogram, and maybe preferably a CT coronary angiogram than an invasive coronary.
Praneeth, second question for you is, we all talk about using aspirin in acute pericarditis. Give me an idea how many acute pericarditis you have treated so far in your professional career, and out of those, how many you treated with aspirin as a therapeutic drug for acute pericarditis?
So not many actually. Few of the acute viral pericarditis, I treated them with what do you call the paracetamol. One or two patients, they responded. One patient was the rheumatic fever and rheumatic pericarditis. That patient I had to give aspirin. So aspirin, the same 80 to 100 milligram per kg. So that dose. So one patient I can recollect whom I treated with aspirin. That was a rheumatic fever and rheumatic pericarditis. For majority, for like acute pericarditis, I could manage him with NSAID, and I could not. There was no need for me to give steroids to any one of them.
You mentioned paracetamol. So paracetamol, typically we don't kind of think it in a way as a treatment strategy for pericarditis. Is it something that has worked for you, at least in some cases?
Yeah, it worked for me. Like with all the NSAID thing that we hear from heart failure and coronary artery disease space, so you are in general very scared of using NSAIDs because you are reminded more of the side effects than the beneficial effects of NSAIDs. So in general, I kind of I'm very hesitant in giving NSAID. So I would first try with paracetamol because it is also an anti-inflammatory agent. And if it can do the job, I'm happy about it. Versus if it doesn't, then probably switch over from paracetamol to maybe ibuprofen or maybe going to steroid.
Thank you, Praneeth. I'll move on. Santosh, you have any questions or comment?
Sir, this is in extension to which patient needs to be admitted. So very important when we are in doubtful situation, even if we think it's 100% viral, such patient needs to be followed up, and at least after 1 week, see the symptomatology of this patient. And after again second week, after second week, repeat the echo, because some of the patients who are tuberculosis cases may land up in chronic congestive pericarditis, wherein we can challenge, we can concentrate on investigation towards which we are going. For example, if it is a COX, we are thinking of tuberculosis, we can concentrate on working towards that diagnosis. If you are thinking it's a connective tissue disorder, so do workup in that line. So what I want to emphasize is that all this patient needs to be followed up meticulously after 1 and 2nd week to know whether if you are in the correct line of diagnosis or if you are missing something.
Thank you so much, Santosh. If anybody else has got any comments or questions or anything you want to share, either you can unmute yourself and speak, or you can put it in the chat box. And while you gather your thoughts, I will share my viewpoints on this particular case, and some of the questions that I asked my attendees, I will tell you what I think about it. So I'm actually bringing the questions in front of me. So does this patient fit the diagnostic criteria for acute pericarditis? I think that has been well established by Shankar sir, who mentioned the criteria, and Praneeth, who described the ECG findings and everything. So I think the diagnostic criteria is more or less fulfilled. The question about pleuritic chest pain, we all understand that the chest pain characteristics at times are not very clear. And, a lot of the times you may not find patients giving you the exact history. So while you are looking for that pleuritic kind of history where an ideal patient tells you, when I take deep breath, it hurts, when I lie down, it hurts, and when I lean forward, it does not. That is too optimistic for us to think about. A lot of patients, they cannot associate pain with these movements. But if you do get one, that's good enough. And all the other findings that people have talked about. How do you decide outpatient versus inpatient? So I have a very low threshold of admitting these patients early on. Even if it is for a day or two, it does a few things like what Santosh was mentioning. Number one, it gives me a little bit time to understand the patient somewhat better. We are talking about pericarditis. We know that the disease has a spectrum where it can be a very mild viral form versus it could be a very severe form. And remember, even the severe disease will start with a milder form to begin with. So we don't know in the spectrum where we are. And being in the hospital even for 24, 48 hours not only helps me define the natural course of the illness early on, it also helps me understand the patient a little bit so that I don't inadvertently underplay the severity of the illness particularly. So that is the reason why I have a very low threshold. So to me, when I do assessment, and if I find anything which is a problem, I will admit. If I get a case which is absolutely 100% clean, then I will not admit. So for me, what are those 100% clean cases? Those are the cases who currently are not having any fever. They're not having any breathing difficulty. Their hemodynamics, as what Praneeth mentioned, are stable. Their echocardiogram did not show any LV dysfunction. Their effusion is not more than mild. In their lab parameters, I would check for a CRP. If CRP is significantly elevated, there is no science behind it, but I would suggest this patient to at least get admitted for a day or two where I can observe. Similarly, I will check for troponin. A troponin positivity means myocardial involvement. In these kind of patients, they can have rhythm disturbances and they can have myocardial dysfunction. So in both of these situations, I would like these patients to be admitted for some time. So as a general rule, as I said, that I have a very low threshold. So if I get a patient who checks off all of these parameters and it's absolutely normal, that is the only patient where I would do an outpatient management. And there also, I typically bring them in after a week to not only do a clinical assessment, but also do a lab assessment, which includes CRP, which includes ESR, and ECG, and I would do an echocardiogram. If the first echo showed pericardial effusion, and if I'm doing an outpatient management, I will check a second echocardiogram within a week to make sure that the effusion is not getting worse. So that is my strategy, initial management strategy. So I will tell you, I have prescribed aspirin for pericarditis, but I could never get the guts to prescribe what the recommended literature is. And that is why I asked Praneeth if he has ever done it. But when I prescribe aspirin, I ask them to take 2 tablets of 300 milligrams 3 times. So I give them 600 milligrams 3 times daily, which is still lower than what the recommended treatment strategy is. Why would I choose aspirin over NSAIDs? So any patient who needs to be on aspirin for any other reason. So this is a 34-year-old guy, but sometimes we get patients who had previous PCI or who had previous bypass or other reason why they need to be on aspirin. In those patients, rather than putting them aspirin and adding an NSAID, I just increase their aspirin dose. But as I said, the max I have done is 600 milligrams 3 times daily. The guidelines would suggest you should do about a gram 3 times daily. But so far that I have not practiced yet. I agree with Shankar sir that NSAID remain the drug of choice. I typically don't give endomethacin. I give ibuprofen because I'm quite well familiar with that drug. And I give a full dose. I start very hard. I start 800 milligrams 3 times daily. And within a few days, I go back to 600 milligrams. And after that, within a week, if I check the parameters, if parameters are looking good, then I wean down to 400 milligrams 3 times daily. And I again recheck parameter within a week. So if after 2 weeks, all the parameters are normal, then I stop it. That is typically what I do for ibuprofen. Endomethacin, I have it probably just the training. I use endomethacin exclusively for gout pain, but I'm pretty sure endomethacin works absolutely fantastic for acute pericarditis as well. Minimize the risk of recurrent pericarditis. This is Shankar sir has mentioned, colchicine is the drug of choice. The only thing that I would add on to that is I typically load people with colchicine. So what I do is I give them 1 milligrams twice daily for 3 days. And I tell them to wean off to 0.5 milligrams twice daily, either on 4th day or if they develop diarrhea. So if they develop loose motions on day 2 itself, then I back it off to 0.5 twice daily. But if they don't develop loose motions, then for 3 days, I give them 1 milligrams twice daily, followed by 0.5 milligram twice daily. The duration is 3 months, which I typically follow. When can you go for cholecystectomy? This also, Shankar sir, I agree with you. I would actually like to defer elective surgeries for at least 3 months. But if a surgery is time sensitive, then I would think even after a month, a patient can go for surgery. Diagnostic tap, Praneeth has mentioned very well, when you put a needle in a pericardial space where there is less fluid, then the needle can go and hit the RV and it can cause problem. But I do have a low threshold for doing tap if the fluid level is high, not only to relieve the tamponade, but also because I am very, very cautious about not missing bacterial or tuberculous pericarditis. Somebody asked the question about how to differentiate. I think Dr. Ravikiran, you asked the question how to differentiate tuberculous versus viral. So the way I think is Tubercular pericarditis typically would have a far more insidious onset. These are the patients who complain of weakness, fatigue, low-grade fever over months or weeks. And bacterial pericarditis, they typically never are fever-free. They are typically never afebrile. So when I follow my algorithm, those patients who are absolutely afebrile, don't have any other issues, ESR is normal, CRP is normal, these patients highly unlikely they have tuberculosis or bacterial pericarditis. But word of caution, patient with mild degree of pericarditis, but who tell the symptoms are going on for about 2-3 weeks or so, please think of tuberculous pericarditis as one of the differential. We are in India where tuberculosis is still common. And very fast, very robust course would suggest bacterial. So that is also something that one has to think about. Santosh asked, what are the peri-procedural complications if patient undergoes surgery? Santosh, I don't particularly know if any of the procedural complications are going to get worse. But what I do know is when you give all these therapies, then your risk of inducing problem just goes high. Like, for example, in a patient with pericarditis, am I comfortable giving anticoagulation? Probably not. Now, in surgical cases, sometimes you give anticoagulation, sometimes you give prophylactic heparin or whatnot. So these are the drugs I'm not happy to give because I don't want a patient who otherwise do not have any effusion now develop a hemorrhagic effusion because of this. Secondly, remember, pericarditis will not show up on ECG if only parietal pericardium is involved. It will show up on ECG if visceral pericardium is involved, because parietal pericardium do not have any electrical signal whatsoever. So the fact that you have ECG changes, that means visceral pericardium is involved. So whether your troponin is positive or not, you have very close myocardial involvement. And these kind of patients, I would suspect, they will have slightly higher risk of arrhythmias when you put them through surgery, particularly GA or whatnot. So I mentioned about elective surgery where you really have no price to pay for delaying these surgery. If you go by the guidelines, what guidelines say that elective surgery should be deferred till the inciting etiology which led to pericarditis is resolved. In this case, let's say if that inciting etiology is viral fever, then once the viral fever has subsided, technically these patients can go for surgery provided all the other criteria are fulfilled, like I said, which is troponin is negative, echo is normal, and all those kind of things. For a viral infection, that would be maybe 2 weeks or so. I still said 1 month for a time-sensitive surgery and 3 months for elective surgery because these patients, they have no penalty to pay for just delaying for some time. We still don't have a very good understanding of how they are going to respond once you subject them for surgery. And remember, these patients will still be on colchicine when you are treating them. Now, would you want your patient to go for surgery while getting colchicine? Again, it's a low-risk drug, but how does it interact and whatnot? It gets a little bit messy. So a better idea would be simply just avoid surgery for 3 months and then go after that. So that will be my take on it. A little bit more conservative, but I have my own rationale of why I am saying it this way. So that is what I would do for these kind of patients. And I'm sure that we heard from our other attendees about how they practice as well. I will invite Somaraju sir for his opinion about today's discussion and if there is anything that he would like to add. Somaraju sir.
Thank you, Anoop, and Praneeth, and everybody. Good evening to everybody. First, a confession from our generations and successive generations we used to practice. We moved away from using steroids as the only drug in acute pericarditis to moving on to colchicine and trying to use less and less of steroid, and also moving on to use NSAIDs, which we used to think as a contraindication some time ago. Now, even the newer drugs like anakinra and IL-1 inhibitors. And now they are approved in US and they are costlier, but they are IL-1 inhibitors are considered to be the drugs of first choice to prevent recurrent pericarditis. Having said that, a few things I have to also mention. Don't go by the published evidence of from the West and also your up-to-date type of articles that the commonest cause of pericarditis is viral. It's not yet so in India. Tuberculosis still remains in the background of all the patients we see, and we tend to miss. And the duration of illness is quite unreliable from the point of view of symptoms, etc. And an ESR of 52 should make you still consider tuberculosis as still a possibility, because ESR elevation is not that common, particularly in uncomplicated viral illnesses. Many times we see. And the CT chest has a role in trying to distinguish or recognize tuberculosis with mediastinal adenopathy as a guide to significant number of patients. And having said that, coronary angiography, I fully disagree with that type of practice. And if some institution, which was some institutional practice, they must publish it. We want to learn. Thank you.
Thank you so much, sir. I think that steroid practice, I remember my seniors telling me that how the overall scientific committee has moved from an steroid first practice to now more of a non-steroidal based practice, not because the drug doesn't work, but because there is very high incidence of recurrent pericarditis. And sometimes those recurrence becomes permanent. Literally, you can't break that cycle. So that steroid first strategy has definitely, we have moved away from it. And interleukin inhibitors, I have never used it. And I'm sure they are costly drugs. I'm sure they work. But so does ibuprofen. Ibuprofen in acute pericarditis, you all have seen for gout pain. It works like magic. These are inflammation-based illnesses. You give one dose, and by the time second dose is given, the patient's pain is completely gone. You know that how effective these drugs are. And Santosh, to answer your question, which Somaraju sir already answered about angiography, I would do angiography only and only in cases where I have diagnostic dilemma. If there is no diagnostic dilemma, if it is quite clear that I'm dealing with pericarditis, I don't care what is the level of troponin. These patients are still diagnosed as myopericarditis and do not require angiography. CT coronary angio can be a compromise, but mind you, all of these patients universally are tachycardic, and doing a CT angio in these kind of situations is quite challenging at times. And more so, I don't think it is needed in most of the situations. So that is what my take on this is. If there is any other thoughts or questions or comments, you can please share it. And while you gather your thought, I will ask Praneeth to give his closing remarks on today's discussion.
Yeah, Anoop, one of the important entities, though not common, but definitely you encounter in your daily practice and you should be aware of it. As the sir mentioned, probably should not be in a presumption that viral pericarditis is not the only one being common. Tuberculosis pericarditis can also present in acute fashion. Any pericarditis, the treatment essentially would be to reduce the inflammation. Anti-inflammatory therapy also has evolved from steroids to NSAIDs to currently molecular targeted agents, biologicals. Probably that will be the future where we have to familiarize ourselves using these molecules as well. And probably getting the patients admitted for a day or two to observe and make sure that they are not deteriorating or not having any complications is worthwhile. And looking into full panel of inflammatory markers to do serial measurements to understand how in which direction they are going, and have very high threshold for angiogram shouldn't be done, because inflammation is actually aggravates the problem. So unless there is any strong reason, angiogram should never be done. And when in need, look for etiologies, be it viral, tuberculosis, or inflammatory conditions like rheumatoid arthritis and SLE as well. So uncommon presentations, but definitely everybody should be familiar or be reasonably confident enough in managing these patients. Thank you.
Thank you, Praneeth. Thank you all of you for attending today's session. As you all know, we do this every Wednesday at 7 p.m. We will meet again next Wednesday. And before I close, I just want to share something. When we started doing this program 2 years ago, we were actually starting this program at 7:30. And with the feedback that I got from the attendees, very soon we shifted from 7:30 to 7 o'clock. And for the past, I believe now 70 odd sessions or so, we have been doing it at 7 o'clock. Recently, I have got a few requests from non-attendees, from those people who are not attending the sessions regularly, that if the session would be at 7:30 or 8, then there may be a little bit better attendance for this discussion. I understand that some few things which are late for few people and it's early for few people. We are going to continue our discussion at 7 o'clock for the next few weeks. But if any one of you have any thoughts to share about whether we should continue at 7 or whether we should move to either early or late, please share your thoughts on the WhatsApp group. I'm amenable to revise the timing, not for the next few sessions, but maybe following that, if we all believe that that suits us better with our clinical work and whatnot. So I just wanted to share that with you. If any one of you have any thoughts regarding this, please let me know on WhatsApp. We can probably discuss it further in a more democratic way rather than more authoritative way. Thank you so much. Good night. We'll see you next Wednesday at 7 o'clock. Take care, guys.